Midazolam is a benzodiazepine commonly used as an induction agent during rapid sequence induction and intubation because of its relatively rapid onset compared to other benzodiazepines. It works by binding to the GABA-A receptor complex, increasing the frequency of the chloride ion channel opening, leading to the hyperpolarization of neurons, which subsequently leads to its characteristic sedative effects. Like all benzodiazepines, midazolam's effects on a person are only sedation and amnesia. There's no effects in augmenting pain or in pain relief. The molecule is highly lipid-soluble, and so it's absorbed rapidly and crosses the blood-brain barrier quickly, leading to its rapid onset of clinical effects. The dose for midazolam for RSI is 0.1 to 0.3 milligrams per kilogram as an IV push. A common dose used in emergent situations is just the dose 0.2 milligrams per kilogram as an induction dose. So, for a 70 kilogram male, they would receive a 14 milligram dose as an IV push for induction. Keep in mind that midazolam is also commonly used as a medication for other reasons, such as in procedural sedation, for seizures, and anxiolysis, but at different doses. A misconception that midazolam is administered at the same dose for induction as with these other indications often leads to underdosing of the medication. Compared to other benzodiazepines, midazolam has the fastest time of onset, achieving its sedative effects within 30 to 60 seconds, as opposed to lorazepam and diazepam, also commonly used benzodiazepines, with sedative time of onset in minutes, which is a little too slow for an emergent procedure such as RSI. After midazolam is administered, you could expect a duration of action between 15 to 30 minutes, after which post-intubation sedation should be started. Conveniently, midazolam could also be administered as a continuous infusion for sedation as well. Midazolam can cause dose-related myocardial depression leading to hypotension. Even in healthy patients, drops in mean arterial pressure of 10 to 25% have been reported. This tendency to induce hypotension limits midazolam's usefulness in the setting of hypovolemia or shock. In these cases, other more cardiostable induction agents such as etomidate or ketamine should be considered. The only true contraindication to the use of midazolam is prior hypersensitivity or an allergic reaction to the medication. Otherwise, if shock or hypotension are not a concern in your current clinical scenario, then midazolam is an excellent choice for induction in RSI.